I gave the introductory talk today, and we have two very recent publications. The first one was the EU policy document, which I wrote with a number of my European colleagues, which really is calling for action that we put together a lung cancer screening plan and ask for an expert group to be set up by the EU Commission and to take it through the various procedures within Europe so we will implement lung cancer screening. But actually, more importantly, I have also put forward the paper that we have published today in Lancet Oncology, which is the EU position statement on lung cancer screening. Now, this has been prepared by 22 individuals across Europe, probably over the last year. And the most important consensus that comes out from this is that we need to start planning now. This will take us about 18 months before we can actually implement lung cancer screening. Well, first of all, we have to look at the service provision. Do we have enough radiologists? Unfortunately, certain countries we don't. So should we consider central reading? How we undertake that reading, we need to put quality assurance in and the training for these radiologists. But actually, taking a step back, we also need to identify the high-risk populations. And in the UK, we used the Liverpool Lung Project to actually develop our risk model, and that was used in the UKLS. There are a number of risk models that are available, but we need to identify the high-risk individuals within the population that will benefit from screening. Also, we need to think of, once the service is being put in place, do we have enough CT scanners available? Should we be thinking of them in static sites, or should we be considering them in mobile sites? It'll probably be a mixture of both. But it's all around putting the systems in place so in 18 months' time we can actually start to screen, probably in a phased approach, and demonstrate it works and then start to expand the process. Well, we have probably about 7 trials in Europe. All of them are slightly different. The UKLS was probably the last of the European trials, so we learnt from all the others, especially the Nelson. So there are a whole range of areas that we have demonstrated. We can bring in the population, we can look at a high-risk population. We have the right material, we feel, for approaching the population, as in the harms and benefits, so they are consented into the whole process. The risk model that we decided to use 5% over 5 years. Probably, if we were implementing this, we would look at a lower rate, probably more like 2.5–3% risk over 5 years. Once we undertake the CT, we need to make sure we have the right quality assurance. We had a very good system within the UK at the time. We had double reading. We have to see how that can take place if we had a larger national and even a European level. We need to think of developing national registries, probably linked into a European registry. We can learn from that by having large data sets of big data, looking to the future, data mining. So we look at the next level of how we actually interrogate the data. And then the individuals, how the decision is made for the management, and that came out in our EU position statement, how we manage these patients depending on the volume and the volume doubling time of the nodules, the repeat scans, and then being referred through to the MDT. So we have developed all of the pieces of the puzzle that are required, and we feel we're now in a position to start planning to implement. Well, the cost effectiveness is really based on QALYs, and if you look at the American trial, it's a very different health service system, and they had a much more, let's say, looser inclusion criteria, and they came out at $81,000 per QALY, which would be very high from our point of view. We went for a high-risk population in the UKLS, and we came out with probably around £8,000 per QALY. Now, if you look at NICE, which works at around the 20,000, we're well within it. So we feel that actually at this moment in time, and other modelling that's been undertaken by the Dutch and Canadian groups, it looks, if you have CT screening and smoking cessation put together as a joint program, they will both be cost effective. In 48 months' time, I would hope that we have CT screening up and running in the first phase, demonstrate it works, and planning for the fuller implementation in the following 3 to 5 years. In order to take this forward, Each country has to make its own decision. They have their own health services and they have their own ways of making a decision. However, we should utilize the European Commission methodologies to bring through. So at the moment in time, they have approved screening for cervical, breast, and for colon. We want to actually work towards including lung cancer on that list and having the support of the Commission and then talking to the 28 countries at this moment in time of how they will implement it. So the support of the EU Commission would be extremely important.